You may start now, Professor Salah.
Okay. So, good evening, everyone. My name is Mahmoud Salah. I am the consultant vascular surgeon and the head of vascular surgery in the Saudi German hospital Jeddah, and I'm also the chief of surgery Saudi German hospital group. We are very happy to have our speaker, our guest speaker today, Professor Martin Stork. Martin is a chief of vascular surgery in Karlsruhe Hospital in Germany, and he's also a professor in Freiburg University. Martin is a visiting professor in our group, Saudi German Hospitals Group. Also, he is one of the group who put these guidelines he is going to talk to us about today. So he participated actively in these guidelines. So we'll be happy to have one of those people who put the guidelines with us. Our panels today, we have Dr. Nashon Al-Attab. Dr. Nashon is Chief of Vascular Surgery in King Fahd Medical City in Riyadh, and he's also visiting consultant in Saudi German Hospital in Riyadh. We have Dr. Abdurrahman Ahmed. He is consultant vascular surgeon. He's assistant professor in Ain Shams University, Cairo, and he is our chief of vascular surgery in Saudi German Hospital, Cairo. We have also Dr. Farouk Al-Alfi. Farouk Al-Alfi is a consultant vascular surgeon, and he is the head of vascular surgery department in Saudi German Hospital in Medina. We will be very happy to have Dr. Martin today. Dr. Martin will talk about why and when we need treatment for asymptomatic carotid stenosis. New guidelines. Dr. Martin, the mic is yours.
Thank you, Dr. Mahmoud, and hello, my dear colleagues and friends, and hello, dear audience, ladies and gentlemen, dear colleagues. First, I would like to thank for the honor of being invited to give this lecture to you, because I know there are very fantastic experts of vascular surgery in your country, and especially in the Saudi German Hospital Group. I have joined this, I think, the first time 6 or 7 years ago, and we became good friends with Dr. Salah, and I did very interesting cases, and I worked in 4 of the Saudi German hospitals. And I think the topic we discussed today is a very interesting topic, because we're talking about asymptomatic carotid stenosis, which is something that has no symptoms but can be dangerous and can lead to stroke. And what we're doing is we're doing preventive and prophylactic medicine and prophylactic surgery. And but we have to rely that the patients are referred to us, and that's why I hope that we will have many physicians and neurologists also listening, and maybe they can share with us the guidelines and the evidence on who should be referred, who should be treated above best medical treatment, and why this is so important. And we selected this subgroup. You know, there are some countries in the world where asymptomatic stenosis are treated to very high degree, for instance, United States, but in other countries like Denmark, almost nobody is treated. Now I try to get the next slide and it doesn't work. Just a moment, please. I have to go out again. Just a moment, please. I have to check this for a second. It worked before. for some reason. Aha. Go back to the meet, the Zoom. Just a second.
Take your time, Mort.
Oh, there's something technical problem here. The Zoom doesn't open. Now, there we go. Can you see that? Now, can you see the screen now? My slide?
Yes, we can.
Yes, we can.
Okay. So why is invasive treatment so important, and why do we treat it before a neurological symptom or stroke occur? So what we do is we do a secondary stroke prophylaxis. Secondary means that the disease is already there, but has not yet lead to a stroke. And how effective is this method? In these few studies available, we can see an absolute risk reduction of 4.5% over 5 years. This means we need to treat 24 patients to prevent one stroke. This seems to be a very high number, but compared to other treatment forms in medicine and compared to other medications also, this is actually a low number. As compared in symptomatic stenosis, it's only a number needed to treat of 2 to 3. So what is the topic which is new, and I would like to stress during my presentation, it's that patients with progressive stenosis, so that means they have to be observed every 6 months, or patients with unstable plaque or previous history of TI and stroke are risk patients to develop a stroke if they are not treated by invasive method. This means that they are on danger despite best medical therapy. So this is a very recent study published last year, a single center study, and they followed all the asymptomatic patients. And what you see here is what happens to these stenosis. So this was mild to moderate stenosis, and you can see here 24% of the patients with a carotid stenosis, asymptomatic, will progress. That means they will develop a higher degree of stenosis, and we know that if the stenosis becomes high grade, it's becoming more dangerous to embolize and become symptomatic. So this means why wait until this occurs? Also, there's a 16% mortality of any reason, stroke and myocardial infarction and death, which tells us that patients with a carotid stenosis are in generally high-risk patients that should also be very well followed for cardiovascular complications. So what happens if patients are carrying a plaque in their carotid artery? They can embolize, and this is a main danger in these patients. And there is nobody, and no neurologist can really predict for every patient which patient will develop a stroke if he has such a stenosis as you can see here. This is a typical eversion endarterectomy, and you see here the very tight lumen, and you see this very soft plaque here with many ulcerations and thrombotic lesions, and there's embolizes, and you see here the surgical result of the eversion endarterectomy and the intraoperative control, where the stenosis is removed, but it's not just that the stenosis is removed, but that the source of embolization is removed. And in my opinion, best medical treatment is not always safe enough to prevent this. So in generally, as you all know, but I would like to stress this again, we have 3 columns of treatment. We have the conservative treatment, we have interventional and operative treatment. So let's talk about conservative treatment. Conservative treatment is that if you make the diagnosis of extracranial carotid stenosis, that implies that you have to take care of the patient for blood pressure monitoring. You give him aspirin, a statin, smoking cessation, and many other things, diabetes control, which is actually a lot of work to do, and the patient needs a lot of doctors to make sure that all these aspects are really taken care of. The interventional treatment, which is a little bit popular in the last years, becoming better and better from technical aspects, they have to consider if you do this, is it the right selection of patients? We'll come back to this a little bit later. They should use a cerebral protection device, which makes it a little bit more complicated than regular stenting in other regions. There are also devices like flow reversal. There are new stents like the new Terumo stent with a dual layer mesh, which is more safe to prevent intra-procedural embolization. And we have, we're not talking about this today, the hybrid procedure, the transcervical carotid artery reconstruction, the TCAR. And we have operative. I showed you already the technique of eversion and arterectomy, and the alternative is patch angioplasty. So if there is a patient with carotid stenosis going to a primary care physician or to a neurologist, who will actually decide which treatment will be offered? You see here, this is a practitioner or neurologist, and this is a surgeon, and maybe the stronger person will decide. That means the doctor should try to reach an interdisciplinary decision. It's not just one doctor who can really have all the overview of all these treatments, but you need to involve a specialist, a vascular specialist experienced in treatment of this. So again, how do we select which therapy is best for asymptomatic stenosis? This is a main question in this field. And of course, every patient, whether you do intervention surgery or not, even if you don't do it, should be treated by best medical treatment. And this involves at least a statin and aspirin, and nowadays also the low-dose rivaroxaban, which is not on a high evidence level yet, but maybe in the future will become important, antithrombotic treatment. But anyway, even in worldwide studies like the ACS2 study, not every patient is treated by a statin in the right dose. It doesn't make sense to give a statin of 10 milligram atorvastatin, which is not really not enough, and the LDL value should be less than 100. And I'm not going too much into this lipid management guidelines, but they should be aware of that for these patients with carotid stenosis, they are of high cardiovascular risk, and they should be really monitored for lipid management. And from a morphological point of view, if you see the picture of, I'll show you a few in the next minutes, from a morphological point of view, an estimated 95% of patients can be treated by either CAS, stenting, and arterectomy. So actually, it's a hard decision. If I'm always asked after these talks, or many experts, what is the criterium to use stenting and arterectomy? And actually, it's the experience of the therapeutic of the doctor who can do best, and the quality of stenting should be on a very high level, because in the randomized studies, I'll show you a Cochrane review later, CAS stenting is having a hard time to prove that it's just as good as an arterectomy, and many are not convinced that it's really the same problem. So conservative therapy may be very difficult and frustrating. I told you this, and also it's a question of diet. I find this very funny. This is actually a restaurant in Texas selling these burgers. It's called the Heart Attack Grill. And you have the single bypass burger, you have the double bypass burger, triple bypass burger, you have butterfat share, and you have deep fried flatliners, fries, and some soda and candy and cigarettes. And this is what the patients like. And if you tell them they should stop this, by now, usually it doesn't work. How about surgery? Surgery is an old lady. Surgery was introduced in medicine very early in 1953. The first arterectomy was performed by Michael DeBakey in Houston, actually a cardiac surgeon, but he was a pioneer in vascular surgery, known to everybody. And since then, many randomized studies and a lot of experience in this vascular procedure, which is actually much older than femoral popliteal bypass and other procedures we are doing. So we actually have a big knowledge and experience with this method. The second one was performed 1 year later by Eastcott, actually in the way we do it today, because Michael DeBakey did not use the patch or eversion. So what is effective? For symptomatic stenosis, the Cochrane review, this is already a review from 2017, there's a new one available in 2020, showed that the best you can do is to treat high-grade stenosis. So if you have 70 to 99% stenosis, or even 50 to 69, you see the risk reduction is less, 23%, but here the highest effect is seen if you treat high-grade symptomatic stenosis, and this is actually agreed upon worldwide, even among neurologists. If there's symptomatic stenosis, that means patient has a TIA or minor stroke, it should be referred to surgery. In our guideline, we say within 3 to 14 days. This is a limit. After that, it's a lot of high danger that there will be a second stroke. But so what do you do with a case like this? This is now the asymptomatic patient, and you see this is the way how we analyze in our radiology department the area of the stenosis and the degree of the stenosis from a morphological point of view. You know, the duplex scan is giving you the peak velocity aspect, and this gives you like a geometrical analysis, because the nested study was actually done using only geometrical studies. There was no PSV measurement at the time of the nested study, which has actually proven the effectiveness of symptomatic cases being operated. You see, in this case, it was stent was chosen because both was possible. Patient was given also a choice, and he selected a stent. You see a nice result. But what you also see is sometimes in the stenting, more than in surgery, microembolization, and nobody really knows what this means. Some of this will disappear after 2 weeks, so they say it's not really a big deal, but probably more healthy if this does not occur. So this is a ask for effective protection device and good filters. And of course, in stenting, we have a little bit higher rate of embolization than during surgery. There's a lot of papers about this. So what happens after we have done the CREST study? I'm not talking about the CREST study. No, everybody knows it's the largest study done in the United States comparing stenting and arterectomy. And it came out that if you use the endpoint stroke and death, the surgery was better. If you use the endpoint stroke, death, and myocardial infarction, minor infarction, or myocardial ischemia, actually, then both groups were equal in the statistical analysis. But this was not very convincing, because we think this surgery is done to prevent stroke, and therefore the endpoint stroke and death is actually the true endpoint. And there was a year-long discussion what this study really tells us. Also in the CREST, there were asymptomatic patients included, because the recruitment went not faster. But what you can see here is, you see here the elective cases done by this is all carotid stenosis in the United States. This is a survey over 5 years, just recently published in Stroke. You see higher number of surgery than stenting, and stenting a little bit going down. So more people are convinced of surgery than stenting, but still a certain percentage of stenting, relevant percentage, is performed. But if you go to symptomatic patients, you see both are rising, even the stenting and the surgery. This looks a little bit different in the case of asymptomatic patients. Very interesting paper telling you what is really done in the real world. So another case. So this case is also asymptomatic, and in the MR, when you see this, the patient is coming with these pictures. So it's not that we make the diagnosis, but patient comes to our clinic and we he says, I went to the doctor and he made this picture and I have no complaints. So what is the deal? So you see here, it's a near occlusion, or in the MR angiogram, sometimes overestimated stenosis. In the duplex, this was still patent, and it was at least 95 to 99% high-grade filiform stenosis. So in this case, one indication is to keep this vessel open and to prevent stroke, because if it occludes, it can lead to stroke, and also this can still embolize. So we made an interdisciplinary decision. In this patient, after talking to the patient, we recommended endarterectomy because this stenosis was circular, it was strongly calcified, and he had a regular cerebral MRT without any stroke signs or minor strokes. And also the patient had a normal operative risk. And it's very difficult to bring the protection wire system through this stenosis. Actually, you would need proximal occlusion system or flow reversal to treat this. So nobody really was asking that stenting would be an optimal solution for this kind of patient. But this is another case. This patient came to us, referred from the nephrology department. He had a TIA, but it was more than 6 months ago. You see here some older lesions. and was sent for stenting because he was 91 years old, actually in a good condition, but he had a positive MR. That means he had some signs of embolization, but you see on both hemispheres here, and he was on dialysis. And you see here, the left common carotid it's a bovine trunk here and a very elongated arch, and you have to go 3 times around the corp, almost 180-degree back. And it's also not easy from this arm to go into this. And you see here the filiform stenosis, and you see here the circulus of Elisei. And in this case, surgery was done without any complications. Was severe calcified stenosis and would have been very difficult to treat with stenting. Also, we have what is called a hostile neck. You know, every surgeon, we know hostile abdomen, but we also know hostile neck. This is a cancer patient. This is a patient who cannot remove this. And also, this is a morbus Bechterew patient. If a patient is like this, it's very tough to do surgery. In these cases, it might be easier to use stenting just from the regional aspect of the neck. So, but coming back to the very important question, is stenting just as safe as surgery? And does stenting have 0 complications? And the truth is no. This is a CREST 2 carotid stenting registry. And you see here, even the best selected centers in the United States have a stroke and death rate in asymptomatic patients of 1.4%. Actually, this should be 0. And I told you, if we have a number needed to treat and you have 1.4% stroke, that means you need to treat another 24 patients to make up for this. And after patient number 51, you are doing something good for the whole group of patients. So you see symptomatic is twice as high, but still 2.8% actually low. But anyway, this is not better than surgery. The same result can be reached with surgery, and this is a real-life registry. However, when you look at the peri-procedural complication rate, that's a difference to looking at long-term result. And this was one of the first studies using asymptomatic patients, and they were followed for 5 years. Once they have made it through the perioperative period, you see the incidence of stroke and death. This is patient survival. And this is overall survival also due to other regions. This is freedom from stroke. You see there's no difference in both groups. However, this study was not really reached the full sample size, so actually was a little bit underpowered. So it has not the same impact as a real randomized study, but it shows actually very clear that the long-term results, if the patient has been treated by stent or an atherectomy, the long-term result is no difference to observe. So how do we do the carotid surgery? There are 2 ways to do it. There is the classical patch angioplasty with or without shunt. And we have the eversion end atherectomy where you pull back the adventitia and the intimal cylinder is pulled out, and then it's a anastomosis without any foreign material. Another advantage is if there's some kinking, you can shorten the carotid and straighten it up. And actually, in the end, it looks very good. And in the patch group, you have always as a material here, but the infection rates are very low. Very new data show that the best material for patch is bovine, xenogenic bovine patch material. Stenting is a little bit more complicated. If you do a stenting of a stenosis like this, so these are the steps you have to go through. Just briefly, I mean, the experts and the vascular specialists, they know about it, but what you have to know is you have to first put a catheter in the common carotid from the femoral artery through the whole body. You have to introduce a very long sheath into the carotid artery. Then you have to hurry to put the protection device to the distal carotid artery up here to make sure that there's no embolization. And even the first passage to bring it up here can lead to embolization. The question is pre-dilatation or not. There is always big debate at every Congress. Then the stent is actually introduced. Then there's the question, do we need a post-dilatation to mold the stent and fix it? Then the protection device has to be removed without any complications. The sheath has to be removed. And you also have to close the femoral artery using special closing systems. So you see there's a number of steps, and it has to be trained very well. And you have to be experienced in endovascular procedures to do this. There are 3 ways to protect. This is distal occlusion, is almost not used. The filter systems are used, or the proximal occlusion where one balloon is in the common carotid artery, one in the external, and that means there is a flow reversal from the internal artery and no danger of embolization, but this cannot be used in all cases. You have to have a certain diameter of the external and there are some morphological criteria where you cannot use proximal occlusion. Now, what are the results? This is now 30-day results. That means the peri-procedural complication rate, and this is a very new Cochrane database, and this has to be taken into consideration. It shows that the endarterectomy is less dangerous than stenting from a study point of view. That means if the patient these are all the available studies, but you see they're a little bit old. Maybe we will never have a new study, but this available studies here, you come to these results when you look only for asymptomatic patients. There is one study going on, the ACST2 study, 3,500 patients. We are also participating in the studies. They will give us a more clear answer next year or the year after about whether this is true or whether this is actually both of equal safety. But from a scientific study point of view, actually surgery until today is safer also in the case of asymptomatic studies. Now we come to the new guideline. You see, these are very famous German colleagues. This is a vascular surgeon, this is a neuroradiologist, this is an angiologist, and this is also a neuroradiologist, but actually it was 25 societies involved to make this new practice guideline, second edition. And what did this guideline do? It reviewed all available RCTs and meta-analysis in these 6 chapters. 20,000 publications had to be looked through, first the abstracts and then chapter-wise the topics. All existing guidelines were analyzed and judged and see whether they are still useful. And also there are different levels of recommendation. This is very important. These are the guidelines that were accumulated. And you see also there are some neurological guidelines with it. This is the German Society of Neurology, and they agreed on all these recommendations. And this is very interesting because if the neurologists as a society, they agree on a certain recommendation, they should also, as an individual neurologist, follow these recommendations. And you see the newest one is the European Stroke Organization, ESO, a European Society for Minimal Invasive Neurological Therapy. This is the newest guideline, but they're talking actually about mechanical thrombectomy in acute ischemic stroke, which is not exactly the same. Actually, we have this European Society guideline from 2018, which in many aspects is still valid. Here you see the levels of recommendation. This is very important. If you cite a guideline or you read a guideline, you should make sure, is it a strong recommendation, or is it a recommendation, or is it a maybe considered? This makes a big difference, because maybe considered means you can do it or you cannot do it. And there's also expert opinion. Expert opinion means you cannot create evidence, or there is no evidence for certain reasons, for ethical reasons. And then all the experts make a consensus of 90% of the societies. And this has to be taken into consideration. If you see now here the recommendations, and I think if somebody's interested, I can mail this whole text, but maybe a few aspects I copied for you, which we could go through quickly. This is very strong recommendations. That means all patients with asymptomatic carotid stenosis should be recommended to eat a healthy, balanced food diet and take exercise and quit smoking. This is actually the strongest recommendation, but it's very difficult to achieve. I told you in the beginning. A little bit weaker recommendation because we have only level 2A evidence. There are no randomized studies. They should take aspirin, provided the risk of bleeding is low and hypertension should be treated, and they should take a statin. But statin is already expert consensus. There is not really enough prospective randomized studies comparing the group with statin and the group without statin. There's no way from an ethical point of view we can do this. Some more recommendations is in the presence of 60 to 99% stenosis. Now it becomes interesting for us. Carotid endarterectomy should be considered. This is a recommendation. It's not a very strong recommendation, but a recommendation, as long as the surgical risk is not elevated and there's at least one finding with increased risk of subsequent stroke. I'll come to this later. I'll show you the recommendations. What is in clinical imaging or clinical sign for high risk of stroke in asymptomatic patient. Also, the next recommendation, you see, this is maybe considered a little weaker. This is evidence level 1, evidence level 2, weaker a weaker, maybe considered recommendation. In the presence of this carotid stenosis, stenting can be considered. As long as the treatment risk is not elevated, there is at least one finding, the same text. This means this is a little bit weaker recommendation than surgery. And I think we have to tell our patients this. And very high, the strong recommendation is that the rate of stroke mortality should be as low as possible in asymptomatic stenosis. For both methods, the rate of stroke should be monitored in the department and should not exceed 2% during the hospital stay. This is what we ask. If you do treat asymptomatic carotid patients, you should not have a higher rate of 2% complications. Otherwise, the whole collective has no benefit from this procedure. And this is my last slide from the guideline. The choice of surgical procedure, whether we do eversion or conventional CAA, should depend on the operating surgeon's personal experience. In other words, if somebody is feeling better using a patch and doing safe surgery, he should do it. This is a very strong recommendation. So you should not urge somebody to do the eversion because it looks so nice and it has no patch material and nothing. It's not that one is better than the other, but you should do what you are feeling best and what is your routine procedure. Of course, we do both procedures and we teach both, but for teaching purposes and for the control of the patient in high-risk patients, we sometimes prefer the patch angioplasty. You have better control of the whole situation. And this is a question of local regional anesthesia. This is also a strong recommendation. It's in choosing between general anesthesia or local anesthesia, the patient's preference and the individual experience should be taken into account. So it's also depending on the site. So it is not the case that regional anesthesia is better, but if you are doing this and you do it well, you can do it. And for the patients, in my opinion, it's better monitoring possible. And clamping ischemia can be detected earlier in an alert patient. This is what my belief also is. There are some studies that the monitoring is prompter and quicker if the patient is awake. And then the typical recommendation for stenting, you should do dual platelet inhibition, which is not necessarily recommended for surgery. And the treatment of clopidogrel with support should be initiated at least 3 days before the intervention, or on the day before the intervention at 300 milligrams. So that means loading. Loading is very important if you do stenting, and then can continue this for 1 month. But I think this is also the old guideline. So now we come back to this very interesting new topic, and this is really new stuff, cumulated from many, many studies. What are clinical or morphological variables for being at risk for a subsequent stroke in asymptomatic stenosis? So that means men less than 75 years, they have a benefit, and contralateral TIA and stroke, if this is in the history of the patient, this is also benefit. You have a risk reduction of 3. But now we're coming to the plaque morphology, and this is becoming more and more interesting. First of all, if you have silent infarctions on the CCT, they have a hazard ratio of 3. That means 3 times higher risk to develop stroke in the future. Then we also have the extent of stenosis. The higher, the more dangerous, or progressive, the more dangerous. And there are different categories. I will skip this for time reasons. But here we come to the high risk. You see odds ratio between 3 and 6. Echo-poor plaque is dangerous. Bleeding into the plaque. Plaque bleeding is dangerous. Plaque area of more than 80 square millimeter is dangerous. Spontaneous microembolization, this is 6, odds ratio 6. 6 times higher risk of stroke than without. And spontaneous microembolization, and also limited cerebrovascular reserve capacity. That means you do a transcranial Doppler and you find, if you do CO2 breathing, that there's no further vasodilatation possible, then the cerebrovascular reserve is already used. And this means if there is some ischemia, they have a higher risk of ischemic stroke. And very interesting, of course, not everybody can do this, but it's the American Society of Neuroradiology recommends to use the PET to define the inflammatory activity of a carotid plaque. And you see a patient with plaques on both sides in the CT scan, but only in diffused PET imaging, you can see one of the plaque has symptomatic plaque is more inflammatory than the asymptomatic plaque. So the question is, this shows that a symptomatic plaque has more inflammatory. The question is, what do you do if you have an asymptomatic patient who looks like this, who has not been symptomatic? This is the question what studies are going to answer, and maybe this is a very, of course, expensive and complicated technique, but it shows that it's possible to differentiate the plaque activity from symptomatic to asymptomatic or dangerous plaques from less dangerous plaques. And I think in the future, maybe they will have more answers to these questions. So Dr. Mahmoud told me, after all this theoretical and scientific graphs, how do I now really do it? And if I say how I do it, I mean, of course, how do we do it, our team, how we agreed in our team how to do it. Of course, there are some differences in some hospitals and some colleagues who have slight variations. And there is not only one way to do it, but I show you what is our way to do it. So even if a patient is referred to a hospital, we do the duplex scan ourselves. We want to see the plaque in our department, we have the ultrasound, and we use it to confirm the diagnosis from the referring doctor. And there are, of course, two aspects everybody should know who's doing this, examining a patient from my colleagues. First of all, we have to be able to measure the peak systolic velocity. Of course, this is not the only criterion, but it's a good criterion. If this is less than 250 or 200 centimeter, it's not a high-grade stenosis. And sometimes we get patients with MR pictures and other pictures, and then if we do a good duplex scan, and you have to have the 60-degree angle here and really find the point. But if it's only 250 centimeters, it's not high grade by definition. And this, for instance, if you find this is a plaque with an ulceration. You see like this hole here, and there is some turbulences, not in this picture, but if you see a liasing, that means the blood is going in circles. Then it's a dangerous plaque, but any kind of ulceration is dangerous because there can always be thrombotic material lying around in this ulceration, which can embolize any time. According to the guideline, it's always recommended to add CT or MRA scan, not only to show what the stenosis looks like, because we know that from duplex, but to find out, is there a tandem stenosis, how is the aortic arch, and how is the intracerebral circulation. And this is very interesting. If you have CT scan, you can really much better judge the calcium load. If you do MRA, you can better show plaque hemorrhage by the T2 weighting. And so it really depends. Some patients have pacemakers and cannot put to MRI. Actually, we do MRI as a method of preference. So, as already mentioned, we do 90% of the cases in regional anesthesia. That means the patient is awake, but he has sedation, some dormicum and Ultiva, which makes him tired and makes him also forget about everything, which is very important. Afterwards, I cannot really remember, but they should be awake to be able that we can talk to them, and you give them oxygen. And then we do the plexus. There are two ways to do it. It's the deep plexus and the superficial plexus. This is a deep plexus block. If you do the deep black plexus block, you should, the anesthesiologist, whoever is doing it, should use ultrasound control, not to puncture the vein or incidentally to puncture the vertebral artery. I've seen a case where the local anestheticum was injected into the vertebral artery, and the patient developed severe cramps and epilepsy, and we could cancel the operation, and he went to neurologist and to CT scan and everything. So be careful where you put the deposit, but it should be deep enough, and it should be enough to really make it deep. Then we use shunt, but only selected shunting. That means we use the shunt if the patient needs it. So how do we know whether the patient needs a shunt? From a statistical point of view, like every 10th patient needs a shunt because he develops clamping ischemia. And if he is in general anesthesia, it's very difficult to detect the clamping ischemia. So you see here is a regular Sherwood's shunt, which is inserted, and you have to make sure that the shunt is really, there's some blood flow in the shunt. If you put it too far to the skull base, it could be that there's no flow at all, but so we have to make sure that the shunt is inserted correctly. And this is awake monitoring for $2. You give it to the contralateral hand and ask the patient to squeeze. That means the anesthesiologist actually is asking the patient to squeeze. And as long as he can do that, you can feel well. If he all of a sudden he stops doing that, there's something wrong. Then you should put a shunt in, you make the blood pressure higher, and you try to find a reason what's going on. This is the standard neuro monitoring, which is the somatosensoric evoked potential. So you have something here on the hand and you measure the EEG. This has some latence. That means it takes like 5 to 10 minutes. It's not so fast as the awake monitoring until you see those changes. It means the flattening of this curve. You see here, for instance, when you clamp the carotid, this happens. Then you put a shunt in, open the shunt, the curve becomes better. When you put the shunt off to 2 minutes, then the curve becomes flat again. When you reopen the blood flow, you have back the normal curve. So this is a typical example of a patient with clamping ischemia and where the shunt was used, and you have to follow this. So this is a little bit complicated. You can also use near-infrared spectroscopy or other things. We just bought this where you just put 2 electrodes on the front and you measure the saturation of the blood. The only problem is you don't measure really the region of the carotid artery, but the whole brain. So it's not as representative, but it shows you also the changes. So what we always do is we do an intraoperative angiogram using only 5 ml of contrast medium, low pressure, slow injection, and we follow this up to intercerebral to see the branches here. So we can check shot. And you see here the Doppler flowmetry, where we want to see a regular curve, like in these cases, and we see sufficient flow. These are 2 ways to control the reconstruction, and this is a cosmetic result. We can use small incisions. We don't need big incisions, and the whole procedure, if it's going well, takes 60 to 70 minutes if everybody knows what to do. 2 final words about old patients and female patients. So the question is, if somebody is like, as I showed you, the patient is 90 years old or over 80, these are called octogenarians. And the question is, how dangerous is it to treat octogenarians? And you see here a great asymptomatic carotid surgery database from the United States, where they have 2,500 octogenarians, and compared to younger patients, and you see here the stroke and death rate is not significantly different between 2 groups. Mortality is always higher in octogenarians, but this is true for any surgery or anything you do with them. But here, if you just look at stroke and death, this is what we want to prevent. They have no different results from younger patients. So if you select them properly and you do it well, there's no reason why age should be a contraindication for carotid reconstruction. How about female patients? You see here again the risk of stroke and death, peri-procedural risk after carotid and arterectomy. You see here age is a factor, ASA is a factor, but gender, male versus female, really no difference. And this was a lot of patients. This was 14,000 patients from the German registry, all asymptomatic. So we do not believe that the female, there's a lot of discussion about this, but in my opinion, female patients are not doing worse if they're treated by the same caution as male patients, and that's why they should not be excluded. Maybe an exception, exception is female patient over 80 years, never symptomatic, should be reluctant, but this is more gut feeling. So I'm coming to an end, and I thank you for listening for such a long time. What are the real recommendations which we can use as a take-home message? So the highest effect and the most effective treatment is if we treat high-grade stenosis. Don't do surgery on medium stenosis between 50 and 60%. There is no benefit for the patient. And also very effective is progressive stenosis. So if the patient is followed over 1 or 2 years and he has progressive stenosis, then you should do the surgery or stenting, and of course unstable plugs, because they might lead to stroke in the near future. What is new? Identification of risk factors I showed you for subsequent stroke despite conservative therapy in asymptomatic stenosis. This is all listed in this guideline for the first time. And I think this should be taken into consideration and should make us do more and even better duplex sound and judge the quality of the plug. Then the question is surgery or stenting. Depends on the quality of the stenting department, the stenting doctors, but the surgery still has a higher level of recommendation and evidence, especially in the symptomatic cases, but even in the asymptomatic patients. I showed you a Cochrane review showing that asymptomatic patients also have a definitive benefit from good surgery and from stenting if it's done with the same quality. And there are still ongoing studies, and also the materials for stenting is getting better and the protection devices are getting better. So maybe they will improve also the results. Unfortunately, these studies are all finished already. Careful interdisciplinary selection of patients for invasive therapy is necessary according to the current evidence. My opinion, if you discuss from surgery, radiologists, neurologists, there should be a fair and discussion and taking into account all these evidence, which is a lot of evidence now available for the carotid reconstruction, and that's why the patient should really be offered invasive treatment if we know that he has a benefit from prophylactic surgery of a carotid artery stenosis. And with this, I would like to thank you for your kind attention. This is our hospital. This is the city of Karlsruhe with a castle, and we even have a pyramid in Karlsruhe where one of the founders of Karlsruhe is buried below this pyramid. Thank you very much, and I'm looking forward for the discussion.
Thank you very much, dear Martin. It was really a very nice talk, and it was very nice to show us your pyramid in Karlsruhe. Before I give the chance for our panels to discuss, I have a question. You mentioned that for stenosis starting from 60 to 99%, but before 60, we all understand that before 60, you mean this is for the best medical treatment. Okay, but how about if it is 60 on both sides? 60% stenosis on both sides. What would you suggest?
This is a good question. Of course, you would think this patient is in danger, but in all these guidelines, you cannot find a recommendation telling us that the both signs should be defined as a combined risk. So each carotid has an own risk, and if there's a low risk here, that's independent of there's a low risk on the other side. The question would be, what do you do if you have contralateral occlusion, and here you have a 60% stenosis on the other side?
Well, actually, this was my second question. But
oh, sorry, sorry. The much better question. Here we have to, maybe in this case, we should judge the circle of Elisei, whether he has good compensation. And if we have any sign of not perfect compensation, like an incomplete circulus of Elisei, or we have, if you can do this, the transcranial Doppler, and we have reserve capacity on the contralateral brain, or any sign of previous embolization, I would recommend surgery. But on the other hand, just a word of caution, there are some very smart guys from England who write reviews, Ross Naylor. In cardiac surgery, there's always the question, should this be treated by simultaneous surgery if you have an occlusion, a high-grade stenosis on the other side, and you do AZB? Only if it's high-grade. So it should be 60% or more. And contralateral occlusion, this is maybe better reason than what you, in the first scenario, which you said. In the first scenario, I would observe the patient and see, does he develop progression on one side, and then go right and do it.
Okay. But again, if a patient has total occlusion on one side and the other side is 60%, you still evaluate the 60% alone. If there is good...
This is this is a clinical judgment. Of course, you have to, if this is what is called the clinical whole picture, the clinical picture. Of course, then you would say, in this setting, what we're talking about, the stenosis does not have a higher risk of embolization only because the other side is occluded. But since the other side had a progression, it's very probable that this side will also develop a progression. So we can talk to the patient and say, if he agrees, we would cure this, because we are very much thinking that this will also be progression. But it's not proven. It's more speculative. There are some patients walking around with a 60% stenosis forever. It's not a good evidence, let's say, the same as near occlusion. Another question maybe we're going to ask is, what do you do with near occlusion? Filiform occlusion on one side and normal carotid on the other side. In the guidelines, used to say don't touch it, but now they say keep it open. That means we try to do revascularization or stenting even in near occluded carotid stenosis. But it's always a difficult question, and I think you have to talk to the patient and you have to judge the risk. If it's a good condition and has low risk and the patient agrees, you can of course go ahead and do the surgery if the other side is occluded.
But I guess that near total occlusion is completely different from total occlusion.
Yes.
Yeah, near total occlusion, I guess that we should try our best to revascularize this before it turns to total occlusion, and then we are stuck without doing anything.
It's true, but there's only 1 or 2 studies for that, and it's only 14 patients, and the evidence was so low that the European Society recommendation said don't touch it, and the German guideline says, now the new one, we should try it. So there's a change towards your opinion, but the evidence for this is very low. This is expert opinion recommendation. There's no real evidence. Today we're talking a little bit about evidence. So what is proven and what is maybe good.
Okay, we can see for our panels, I guess we'll start with Dr. Nashon, if he has any question or comment.
Yes.
Dr. Nashon.
Yes, thank you for hosting me in the most interesting and controversial subject to discuss and share also different opinion and experience in treatment of asymptomatic carotid artery stenosis. Also, thank you for Prof. Martin for the comprehensive presentation and also the guidelines in treatment of asymptomatic carotid stenosis. I would like just to share our very modest experience in treatment of carotid artery stenosis. I would start with the governmental hospital, especially the King Fahd Medical City. Usually our cases referred from the neurologist, and most of the time or always they are the cases that are referred to vascular only symptomatic with near total occlusion or ulcerative plaque. And some cases of symptomatic, or most of the cases refer to intervention neurologist. For asymptomatic cases, I usually accepted cases from outside hospital, from the tertiary, from other hospitals, secondary hospitals, primary hospitals. So I think most of us still stick to the guidelines. Nobody has its own practice, especially in treatment of carotid, and because this is high risk. It has a high risk of morbidity, especially stroke. So for my own practice for asymptomatic, I usually do the cases or the patient who has high grade stenosis, around let's say the 90%. I go also with the patient wish, because patients came panic from other hospital asking me to do the surgery. Second thing, also the patient has a history of stroke in the other side, or he has contralateral occlusion. Almost same points that Prof. Martin has mentioned, in addition to high risk stenosis, high risk, high risk plaque, those ulcerated or has hemorrhage, even by MRI or by ultrasound. Unfortunately, I would talk a little bit about private practice. We never see carotid artery stenosis. We never see in our private clinic, basically because there is a deal between neurologist and neurointervention. They refer all cases to neurointervention, and they do all cases by by stenting. And I have never seen any case in private. This is my own experience. For asymptomatic, we do carotid endarterectomy. I have done a couple of cases, like 4 or 5 cases stenting. That was patient has hostile neck or high mortality. MI, recent MI. And also, if the plaque is unstable, I would not go with stenting. I always go with carotid endarterectomy. I have done local anesthesia, about 2-3 cases, but most of the time we go with, I always do general, always shunt, always patch, never do stomach pressure and all this. The last point I would stick to it is the definition of what is the best medical treatment, because the population in Middle East is absolutely different from Europe. So if you ask the patient to exercise, they never exercise. There is obesity, there is diabetes, hypertension, and most of the cases we are seeing are not well controlled. Even the cholesterol, even the patient sometimes he's in medication, but his LDL is still high, and you have to achieve less than 70, as you know. So I would like practice according to the patient condition. If the patient has like ejection fraction low, has high cardiac disease, I would and female, old lady, I would just treat her conservatively. If the patient is young and has a high grade stenosis and anatomy is feasible, I would go with the carotid endarterectomy even for asymptomatic, because people are not very compliant to medical treatment. And I think if you save one as you mentioned, if you prevent one stroke, that means a lot to the hospital, to the patient. Even if you operate in 20 cases and you prevent one stroke, I think it is cost effective. So I believe this. Thank you.
Thank you very much, Dr. Nashon, for this comment. Apart from complaining from our friends in the neurology that they are sending the patients to the neurointervention, but I guess practice in the private sector definitely is different from practice in governmental hospital. Yeah. Dr. Martin, you have any comment about what Dr. Nashon said?
Yeah, I think what he said is that we completely agree. All these aspects which you mentioned is also my belief. I just want to make 2 short comments. The European patients are not very compliant to medical treatments. They keep smoking, they are overweighted, and especially if they are at cardiovascular risk, they don't understand or they don't want to change lifestyle. This is the same problem here. And we have every year like 127,000 deaths alone from smoking, and this actually would be more effective to prevent smoking than doing carotid surgery. But anyway, and the second thing is I'm surprised that in the private sector, for some reasons, there's a different treatment option than in governmental, because I think the medical evidence is there, and maybe there should be discussion started or tried again, that the patients should at least be informed or offered surgery, even if it's only a minority that will choose surgery. Depends how you talk to them. And I know that the setting is different if they can go home next day and everything is easier. But I think also private patients in private hospitals, this is not just this hospital, it's everywhere in the world. They should be at least be informed properly about all methods, and they should have a chance to talk to a vascular surgeon, even if we are considered as dangerous people who want to do surgery all the time, which is not true. We are very differentiated, and we also know whom to recommend to conservative treatment. As you mentioned, you have patients where you say, no, I would rather prefer a conservative treatment. This is a dangerous setting and you will have no benefit. And I think this is only what I can say, but I thank you very much for your comment. And I think it is just the same thinking.
Yes.
Thank you very much, Martin. We can go to Dr. Abdurrahman, our guest panel. I guess you have some comments or questions,
Yeah.
Abdurrahman?
Yes, thank you, Dr. Mahmoud. Thank you, Dr. Martin, for your informative lecture. Actually, it eliminated too much points for me. To make it short, I will not take time. Really, in the art in Egypt, we never see asymptomatic patients, except when it is referred to us from cardiothoracic. When the cardiothoracic is preparing for CABG, they routinely do carotid screening. If they found a carotid lesion, whatever the stenosis is, they refer for vascular opinion. They don't refer to neurology. For myself, I operated too many cases asymptomatic, referred from cardiothoracic preparing for CABG. Otherwise, neurology doctors never refer to us asymptomatic patients. So this is my first question to Dr. Martin. What's the rules regarding asymptomatic preparing for CABG? Do you prefer to do it prior to the surgery? And I want to know your opinion regarding this one. Second question is how the contralateral carotid disease affect your choice regarding shunting and patch or non-patch for the decision for asymptomatic carotid. The third and last question, the timing you prefer to do carotid interventions in symptomatic or after stroke. This is my questions. I want to know your opinion, Dr. Martin.
Thank you very much for these questions. So let's go. I'll make it a little bit short. It will not be too long. We can have a whole session on combined surgery. There's a very extensive review by Ross Naylor telling about you can do staged procedure in the sense of doing the carotid first and then the cardiac. You can do simultaneous, doing it at the same time. This is done in a few big centers. And you can do reverse stage. You do the cardiac first and then the asymptomatic carotid later on. And in the asymptomatic stenosis, there's no big difference from statistical point of view, but it is recommended in the guidelines and the guidelines. You do simultaneous or staged surgery only if it's symptomatic stenosis or bilateral high grade. This is a situation where this should be done before cardiac surgery because simultaneous surgery is not so safe for some reason because they have stroke rates up to 10% if you do it in the same procedure because they have the cardiopulmonary bypass, they have, or even if they do off pump, it's a question of cerebral protection, cooling, shunting, monitoring. This is all not so easy in the cardiac surgery setting. So if we see these patients, and of course it's nice that they show them to you, you can tell them if you want. I sent you the guideline recommendation. If it's a unilateral 60% stenosis, does not have to be treated before cardiac surgery. It's just not necessary. And Ross Naylor said, even if you have 0 complication rate, there's no benefit for the patient because he might never develop a stroke. But if it's high grade or bilateral, and one of them is high grade, then you should do it before. Or if it's symptomatic, of course. If symptomatic means TIA and needs bypass. And then you should do this. So this is actual recommendation. So the only not recommendation would be middle grade stenosis, unilateral. So you can tell them they can go ahead and do their bypass. Nothing will happen. Of course, you need a duplex scan and see what the plaque looks like.
If
okay,
bilateral high grade, you do one side or both sides?
I would first do one side, the dominant hemisphere. And the second is the question how urgent the bypass is. If it can wait, then of course I would do 14 days later the other side. But if they tell you they need to do bypass very soon and he has like angina or something, then I would maybe do one side. And if I have to choose a side, I always go for the dominant hemisphere. Like if he's right-handed, I would do the left carotid first. Yeah, and the other question was contralateral occlusion. Of course, in contralateral occlusion, there is a higher risk of cerebral ischemia or clamping ischemia, actually, rather than higher risk of embolization. But as we discussed before, we are more ready to do surgery in contralateral occlusion, but we also have higher complication rates. So the available studies show that if you do surgery by or stenting with contralateral occlusion, there is a higher complication rate. So you need to be even more careful doing this and talk to the patient. So if you treat an asymptomatic stenosis with contralateral occlusion, you have a twice as high complication rate. Knowing this, I would still do it. Just be very, very careful, whatever we can do. This is maybe
so you will the shunt routinely.
Yeah, I would probably be ready to shunt, even though I'm surprised in some cases where the vertebral arteries are so good and they don't need a shunt, but we use a shunt in this case. So we are ready to shunt in these cases. But even in these cases, there's a very recent paper that even the anatomy of the circulus oblisi does not always predict the necessity of a shunt. There are patients with contralateral open carotid and they need the shunt. And then there are patients with contralateral occlusion, they don't need a shunt, but in contralateral occlusion will be ready to shunt, be prepared to shunt or do it. If you do it in general anesthesia, I would just do it. If you do an awake patient, we can see. And the third question was the timing, which is a very, very hot topic. So timing after TIA is very easy, as soon as possible. If you see the patient, you should not send him home, but just keep him and do it within the next 2 days, because he's embolizing, he has an embolizing plaque, and it means it's an unstable plaque and he can develop stroke. And if he develops stroke, there is 2 aspects as far as I know in the shortness of time. If you have a cerebral infarction area, the neurologist show you a patient and say, see this, he has a Rankin 3, not so bad stroke. And the area of the stroke is no bigger than 40 cubic millimeters, then it's no problem. Another aspect is whether the patient has a penumbra. That means, does he have tissue around the stroke which can still be saved? Then it should be very quick surgery and revascularize. And so I think to answer this question, you have to differentiate by perfusion MR imaging. Is there a penumbra? That means still vital brain tissue that might be lost if you don't do surgery very fast. Otherwise, we would always wait until the patient becomes neurologically stable. That means he has a stroke, he's in a stable condition, no more worsening, so he's on a stable level, then you can do surgery. And I think there are controversial in literature. Some people say it's dangerous to do it before 7 days, and you should wait at least 7 days, which is, in my opinion, not true. If the patient is stable and everything okay, you can do it even before that. What seems to be dangerous is very early stenting, because they have a very embolizing plaque and very unstable plaque. And stenting in acute stroke, in the papers I know, is more dangerous than surgery in acute stroke surgery. So actually it's a question of optimism. And in these patients, we have a very tight discussion with our neurological friends. We do have friends in the neurology department, of course. So we have to find the best timing. And but if the patient is stable, the stroke is not too big, then as soon as possible. If it's a major stroke with hemiplegia and neglect and all this, then we would send him for rehabilitation care. And then think about if he has, like if these patients, sometimes we see patients with a very good recovery after stroke, after 6 weeks. Then you can do surgery to prevent another stroke if the plaque is still there. But this is very special indication also. So is that a good answer for you?
Yes, thank you. Very clear. Thank you.
Thank you very much.
But it's a difficult topic. It has to be really a lot of thinking.
Yeah. Thanks, Martin, for the comments and answer. Now we can go to our dear Dr. Farouk for his comments or questions. Dr. Farouk, please.
Thank you, Dr. Mahmoud, for this invitation. Thank you, the debatable topic in vascular surgery and intervention. Really, I have many concerns about the relation between the CAD and the cabbage, the carotid and the cabbage, and just to answer this, Abdurrahman. The second issue, no mention for the new updates in contraindication for carotid intervention. Is it any change in these new guidelines or still the same? This is number 2. Number 3, is there any comparative study regarding the outcome between the eversion and traditional techniques, some value? Because in Egypt, some university make the eversion technique now is the standard technique, fast, and they can control the artery well, and they remove the whole plate from the internal carotid and the common carotid. Other issue, practical, we have facing many cases, they came after stroke by time, at least 1 to 3 months in rehabilitation, established stroke, but now they are recovering, no hemiplegia, but they are limping, and they have significant stenosis these patients are fit for intervention or just continue medical-based medical treatment. And in the guidelines, if there is any mention regarding the rate of cerebral hyperperfusion post-intervention or carotid endarterectomy, because no mention or many papers regarding this event that happened. And I think this is one of the major complications post-carotid intervention cases. Thank you. This is my comments.
Oh, thank you. These are 5 questions. I hope I remember them all correctly. So the first question was partially answered about combined surgery. I think we discussed this already.
Yeah.
We would only do symptomatic or bilateral high-grade stenosis as a simultaneous or staged procedure with cardiac.
Yeah.
The second question was the contraindications for stenting.
Yes.
Contraindications for stenting. Is that the question? Contraindications for
stenting for carotid intervention, surgery or casts, whatever.
Okay. I think the stenting is not so indicated if there's severe kinking or if there's intracranial stenosis, or also the question is if there's intracranial stenosis and extracranial stenosis, and the extracranial stenosis is only very medium and you have intracranial stenosis, and it's both asymptomatic. In my case, this will be a contraindication because asymptomatic intracranial stenosis should not be treated, and then the extracranial should also not be treated. On the other hand, when the intracranial is treated and the interventional is passing the extracranial, they would say, why not stent this on the way back? And I think this is a good argument because then the extracranial stenosis is also treated. Real contraindications for an intervention in a symptomatic patient, I don't know. It's only the very bad condition of the patient. If it's like a severe stroke or severe cardiac disease or no good life expectancy, maybe in some cases you would recommend not to do anything. But I think a symptomatic patient, if he is walking into the hospital, he should also survive carotid endarterectomy or stenting. The questions, for instance, maybe to make it a different setting, if there is a need for cardiac catheterization and you have a symptomatic stenosis which is embolizing, I would do the carotid surgery before the cardiac catheter and not wait, because I think the cerebrum is even more important than the myocardial situation. And this is sometimes debate with our anesthesiologists. They tell us, you have a symptomatic patient want to do surgery next day, and they say, no, we need a cardiac catheter first, and he might have cardiac disease. And they will say, sorry, we'll do that afterwards. This is maybe a contraindication for too much diagnostic procedures. And then you said, what was the third question? Surgery after stroke.
Timing,
timing, yes. Surgery after stroke. We discussed this also a little bit, but you said, what about if the stroke is 3 months old, 3 months back, and still stenosis? So the classical definition of a symptomatic stenosis is there is any neurological event within the last 6 months. So that means if there's anything happening last 6 months and there is a stenosis, it's considered symptomatic. And if the patient is in good condition, I would not hesitate to do the treatment of the stenosis. Also to prevent another stroke. Let's say the patient has a stroke, cannot move his hand, but he can get another stroke and becoming necessary of using a wheelchair or lying in bed. So I would always do this. But we have to know that, I forgot to tell this in the discussion, the surgery after acute stroke is very high complication rate. So you have complication rates up to 10%, and you have to tell this to the neurologist and to the relatives. But if you consider the whole group of patients, then even a complication rate of 10% would be beneficial for the whole group because they will get a stroke in 90%. So you can reduce the stroke incidence from 90% to 10%, but not to 0. And we are not magicians. So we have a statistical risk of stroke if you do surgery very early after stroke. But if it's 3 months ago, I think it's not very dangerous. And depending on the clinical, everything around and the condition of the patient, you could do it. And then you mentioned hyperperfusion, post-operative cerebral hyperperfusion. Yeah, I didn't mention because I think it's about 1%, only 1 or 2%. I don't know how often. You have to do blood pressure monitoring. If the post-operative blood pressure or the intraoperative blood pressure are too high, let's imagine you have a stenosis 90%, you open it up and then you let blood pressure through with 160, 170 millimeter mercury. It might be too much for the poor hemisphere. Most of the cases, it's a reversible condition, but you can have brain edema. You need to do a CT scan. That means if the patient is complaining on headache or strong headache after carotid surgery, you need to do a CT scan in an emergency, and then you need to do the regular brain pressure therapy, like elevating upper body and giving maybe cortisone and diuretics, and also put them on a stroke unit. They really need to go to a special department, take care that they don't develop brain pressure. But it's not too often, and it's very hard to predict when this will happen. I think it will happen if the postoperative blood pressure is too high. That's why we are very strict on limiting the blood pressure of 160 millimeter mercury postoperative, even after stenting.
Mm-hmm.
Thank you for your questions.
Thank you.
And I hope we can do a carotid together sometime.
Yes, really. Yes.
I guess Dr. Farouk also asked the question about comparison between the eversion and the classic carotid endarterectomy.
Yeah, this is a technical question, and all available studies and all available guidelines say that there's no difference. Of course, eversion is more elegant because it's faster. The clamping time is 18 minutes. You have no plastic or other plastic material. And if it works well, it's very good. If the plug is rupturing and you need to open up the internal carotid and make some reconstruction using the external and internal carotid and suture together and create a new distal ostium, then it's becoming complicated all of a sudden. So if you're able to manage complications that the plug is not completely coming out, then it's okay, because the eversion technique, the only danger is the incomplete plug removal. And you have to, I think, in my opinion, what my experience or what my teachers told me, if the internal carotid artery has a small caliber, the eversion becomes more complicated, and the danger of creating a stenosis by the anastomosis is high. Also, if it's a very short carotid, if it's kinked, very easy, but if it's a very straight carotid and small caliber, then it can be too short after the eversion. It could be a little bit complicated to make an easy anastomosis, and all of a sudden the eversion becomes complicated. It's difficult to put a shunt in, and so on and so on. So I would do the eversion only in easy cases or in regular cases, let's say. But of course, if it's standard in Egypt, it's fine. It's actually the most elegant method to do this biological repair, as one of my colleagues says, because no material except one suture.
Yes, thank you.
Thank you very much. Martin, I have a question that's usually in the mind of every one of us. If I have a patient with classic symptomatic carotid stenosis, 80% stenosis, classic for intervention. If I send him to interventional or neurointervention, he will definitely tell him how nice is the CAS and how serious is the endarterectomy, because he only do the carotid artery stenting. If I send him to a surgeon that's doing only endarterectomy, no intervention, he will tell him how safer the carotid endarterectomy than the CAS, and how it's a simple operation and this is the best for him. Okay, but if I send him to somebody like you who's doing surgery and carotid artery stenting, what will your first choice will be? Provided that this patient has no hostile neck, no special indication, comes from the 95% that can fit in the endarterectomy group or the CAS group, what will you do for him?
Well, I tell you what, I know what the question is meant, why you ask this. I think
well, it's an innocent question, by the way.
No, it's not innocent. It's a very tricky question. You're not innocent at all. The evidence for surgery is still higher. Actually, surgery is a safer procedure. The only carotid is considered an alternative to surgery. So if there is an interventionalist who can do the stenting, actually they are doing a selection. If they think it's dangerous or it's not so easy or the patient is critical, they send the patient to surgery. That's the other way around. But the surgeons, they have no necessity to send the patient for stenting except for the cases which I told you, like restenosis, radiation neck, hostile neck, or other complications. So I think what we should tell the patient, actually the patient should be informed. This is my credo. You should tell the patient there is a stronger evidence for surgery, but if you want a stent, it's possible in your case, and if you find someone who can do it with a very low complication rate, it's possible to do this. I would not actively recommend stenting as first choice therapy. For me, it remains even today 1B option. In cases where surgery for some reason is not optimal or not wanted. Some patients are coming and telling you, I went to Dr. Internet and they say stenting is just as good, and I know the studies. Then you can tell them, okay, no objection, you can go with stenting. But I think it's no good idea to send everybody to stenting, or everybody is stented without being informed that surgery actually is a high level of evidence. This is the same as you have good and a bad medication. You give everybody bad and cheap medication and not even telling him that there's a better medication. I think as long as we don't have proof that both is equivalent, it cannot be offered in the same strength. So this is why we make guidelines. So I think if you have a choice and surgery is an option, then surgery is a very safe way to do it. And I would tell this to the patient. So I would rather do surgery. It's a small incision, is what I told you. He goes home after 3 days instead of 1 day. So it's 2 days.
Okay, we have a few questions from the audience. One of them saying, after undergone this procedure, what are needs to watch for? I guess he means what we need to take care of after the procedure.
Well, every patient who had undergone carotid surgery or stenting should take aspirin lifelong therapy, which is actually to prevent stroke and myocardial infarction. This is the meaning of using aspirin. And he should take a statin to prevent atherosclerosis progression in general. And he needs, in the first year, twice ultrasound, after 6 months, after 12 months, and then yearly ultrasound to exclude restenosis or progression of disease on the contralateral side. This is the current recommendation. So if you can manage to send him every year to an ultrasound control, this would be very good for the patient, and the combination of aspirin, statin, and of course the rest we talked about, stopping smoking and diabetes control and all this.
Okay, there is another question saying, there is a rule for IVL for carotid calcification? I don't know what he means by IVL. Maybe
IBS, maybe IBS.
No, he said IVL. Maybe he meant something like laser or something like that. I don't think there is a place for the laser, but do you know what's IVL? Or
I'm not aware what IVL is. If he means intravascular ultrasound, it is actually not routine. It can be used to.
He said lithotripsy.
Oh, lithotripsy. Yeah.
Yeah.
This is experimental, I would say. There's not a standard therapy. It's more for kidney stones, maybe.
Yeah. So it is experimental.
Gallbladder stone. It's experimental. I have no.
Okay. Another question. What are the risk factors of subsequent stroke?
Yeah, this is a good question. It's a question of ipsilateral stroke on the same side or contralateral stroke. The risk of ipsilateral stroke is very, very low. If there's successful endarterectomy and the restenosis is usually very smooth, the risk of another embolization from an operated carotid artery is low. In the stenting patient, in the patient that have a carotid stenting, sometimes in the early stents, there was some thrombotic material on the surface of the stent that could again embolize, and very few. There was a study called Cicero study where all the stents were removed, but I think this is history. The modern stents, they do not embolize after they're placed. The risk of contralateral stroke, this depends on, does he have aortic arch embolization, does he have arrhythmia, or does he have plaque on the other side, which has nothing to do with the treated carotid, but it tells us there are some patients who develop contralateral stroke after carotid surgery, which means that the patient has to be followed, as we said, for ultrasound and cardiovascular risk. So it's not zero.
Mm-hmm. I have another question. This from me, not from the audience. about shunting. I know that some people are always shunting. Dr. Nashwan is one of them. And some people, they are never shunting. And some people like yourself and myself also, selective shunting. So this selective shunting, how you select it? And do you know from the beginning that you are going to shunt this patient, or during the procedure something happened that you shunt the patient?
It's too bad that I didn't bring this publication. There is no way to predict the necessity of shunt. Very, very few cases where you can expect that you need a shunt, as we said, contralateral occlusion or cerebral reserve capacity exhaustion, if you know that before. But even these patients sometimes don't need a shunt. I did surgery on awake patients with contralateral occlusion and they didn't need a shunt. Well, I think it's up to the surgeon. This is also the evidence and the recommendation of the guidelines. You can use the shunt as you want, as long as you do no harm with the shunt. If the shunt is placed incorrectly, it can cause dissection or it can be thrombotic occlusion of the shunt. There's very few technical aspects, very special technical vascular surgical aspects we're discussing. I think there's no objection to use a shunt all the time. Is maybe overtreatment for some patients who wouldn't need a shunt, but shunt is doing no harm, and by knowing this, it doesn't make a difference. So you have to make best therapy, and the technique you use is secondary. I think, in my personal belief, I also would doing more selective shunt, but we doing awake patients. If I would do anesthesia and the neuromonitoring is not so reliable or delayed, I would probably do more shunting than I would do in awake patients. This is one of the advantages of doing it awake.
Okay, I guess we
And
can...
also one more sentence. In Germany, in this national survey, it's about 60% of surgeons use a shunt all the time. So
all the time.
2/3, yeah, but 1/3 is not doing this.
Okay. Any comments or other questions from the panels, Dr. Nashwan?
Yes, I have one more question. Just I want, can you, Prof. Martin, can you elaborate what is meant by juxtaluminal plaque area and its relation to increased risk of stroke? I just read it. I don't know how we are not doing this. Is it by ultrasound? Because I have read about asymptomatic carotid stenosis and risk and the stroke risk study, and they mentioned about the juxtaluminal plaque area, that if it is less than 4 millimeter, the risk of stroke is only 1%. If it is 4 to 8, increase to 3, and if it is more than 8 millimeter, it is 5% annual stroke risk. Thank you.
Yeah, this is correct. I'm not sure whether I mentioned this in this list of risky plaque conformations. It's just difficult to find this on a routine ultrasound to really define this plaque area. We don't measure the plaque area routinely. I think this is a scientific finding, and which is very important to know about. And I'm asking you, are you measuring plaque area?
Yes.
All this?
We are using the ultrasound.
Yeah, but we measure the plaque area in square millimeters. No, that's what I mean. We don't do this. We measure.
That's new to me. Yeah. I just read it, so I go through the study. So I just want to ask you if you have any experience about this.
No, not in a routine setting. But it's a very important point. I think we are in the search of finding a subgroup of patients who really have benefit from carotid endarterectomy or stenting in an asymptomatic setting, and we have to convince our colleagues that they send these for surgery or stenting.
Yeah, one more question is not related to asymptomatic, but for symptomatic.
Yeah.
I have been called from a hospital for a patient who has sudden onset of blindness. So on investigation, they found high-grade stenosis with ulcerative plaque. Would you interfere as emergency, or What's your approach in this such scenario?
Is it embolization in the ophthalmic artery? I mean,
yes.
Blindness can also be venous. It can also be venous thrombosis. If it's embolization in the ophthalmic artery, acute occlusion, then it's an emergency. Actually.
An emergency. Okay.
It's an emergency. Yeah, you have to do
So
it right as next possible day or whatever you can do it as fast as possible. Give full dose heparin, give aspirin and Plavix dual platelet inhibition until surgery. In my case, this is a real emergency.
Emergency, okay. Well, what if the patient presented to you with dense hemiplegia of upper extremity? Like I have one case, stroke in evolution. The patient was admitted. He had
stroke and evolution. Okay, so you have a progressive incoming stroke, as you say. So it's getting worse and worse and worse. The patient is still awake. If the patient is still awake,
he presented with TIA, and the fourth day he was referred late from the neurologist, and the fourth day he had dense hemiplegia of left upper extremity with like 2 out of 5 power in the lower extremity. Are you going to do him also as emergency or?
Yeah, this is absolute emergency. It's maybe even same day. Yeah, it's very, very urgent. If you
that was my case. They found a thrombus inside the carotid.
Oh, thrombus, yeah. Thrombus also emergency. I mean, they would remove the thrombus surgically and do an angiogram and even maybe make an intraoperative angiogram whether there is some more thrombotic material. Thrombotic, this is another topic. This is very special always. Thrombotic occlusion of the internal carotid artery for me is always emergency, and it's the best way, this is opinion now, to remove it surgically.
Okay.
No good way. The only exception, if you have intracranial thrombotic, there's a guideline. I showed you the 2019 guideline from the neuroradiology department. If you have intracerebral embolization of the middle cerebral artery, if it's intracranial, then they do with a stent retriever, they go with a catheter through, and then they can try to remove the extracranial part also. But in some cases, it's also combined procedures that where the intracranial part is removed by catheters, and then you do surgery directly afterwards to do clamping of the carotid and remove the big thrombus, because it's very difficult for them to remove a big thrombotic mass from the internal artery. So this is a very special situation. So I think you have to be sure that there's no intracranial thrombotic occlusion in these patients. Sometimes they have thrombus and then it's embolized. And if it's combined extra and intracranial, it's the main topic actually for neuroradiologists. The first, at least they should see the patient if there is somebody around. And not every hospital has this. In Germany now they're trying to establish this at all the hospitals because the major advance in acute stroke therapy is the interventional intracranial therapy. This is a complete different subject. But of course, in some cases, we have to work together with them.
It's always nice to work as a teamwork.
Yes, my opinion too.
Thank you very much. Dr. Abdurrahman, you have any comment or question before we conclude?
Actually, we enjoyed this webinar with Dr. Martin. I hope we repeat this meeting from time to time with different topics. No more questions. Every hot topics are covered, as I think.
Thank you very much. Dr. Farouk, you have any comment or question?
Thank you, sir. This valuable lecture. Thank you very much, Professor Martin, for these valuable guidelines. We will follow, sure.
Okay, thank you very much. We have to thank Dr. Martin Stork for this very nice talk. We have to thank Dr. Nashon, Dr. Abdurrahman, and Dr. Farouk for being our guest panelist for such a very hot, debatable topic. And thank you for the audience. And hopefully we can meet again for another debatable subject. Thank you very much. Thank you very much.
Thank you from my side. Thank you very much.
Thank you very much.
Thank you.